Question 1. A 62-year-old male presents with sudden onset of chest pain, shortness of breath, and diaphoresis. His ECG shows ST segment elevation in leads V2, V4. What initial action should be prioritized for this patient in the pre-hospital setting? A. Administer intravenous fluids to prevent hypotension. B. Prepare for immediate synchronized cardioversion. C. Obtain a 12-lead ECG and administer aspirin and nitrates if no contraindications. D. Initiate immediate transport to the nearest hospital, regardless of its PCI capability. Answer: C. Obtain a 12-lead ECG and administer aspirin and nitrates if no contraindications. The concept tested here is the initial management of acute coronary syndromes, ACS, specifically ST elevation myocardial infarction, STEMI. The keywords sudden onset of chest pain, shortness of breath, diaphoresis, and ST segment elevation strongly indicate a STEMI, requiring rapid assessment and intervention. The priority is to confirm the diagnosis with a 12-lead ECG and initiate early medical therapy like aspirin to prevent clot growth, and nitrates to reduce chest pain and improve blood flow, assuming there are no contraindications such as hypotension or recent phosphodiesterase inhibitor use. This immediate pre-hospital action helps stabilize the patient while arranging transport to a percutaneous coronary intervention, PCI, capable facility, which is the definitive treatment. Question 2. A patient in cardiac arrest has achieved ROSC. What is the recommended target range for systolic blood pressure during post-cardiac arrest care? A. 80 to 90 millimeters of mercury. B. 90 to 100 millimeters of mercury. C. Greater than or equal to 90 millimeters of mercury. D. 120 to 140 millimeters of mercury. Answer: C. Greater than or equal to 90 millimeters of mercury. This question addresses the critical aspect of post-cardiac arrest care, specifically hemodynamic optimization after return of spontaneous circulation, ROSC. The key concept is maintaining adequate perfusion to vital organs. The guideline recommends targeting a systolic blood pressure of greater than or equal to 90 millimeters of mercury, or a mean arterial pressure, MAP, greater than or equal to 65 millimeters of mercury, to ensure sufficient blood flow to the brain and heart. Maintaining stable blood pressure prevents secondary brain injury and optimizes recovery, contrasting with lower targets that could lead to hypoperfusion. Question 3. During a resuscitation attempt, the team leader assigns roles and responsibilities. This is an example of which critical component of effective team dynamics? A. Closed-loop communication. B. Clear roles and responsibilities. C. Knowing your limitations. D. Constructive intervention. Answer: B. Clear roles and responsibilities. The concept being tested is effective team dynamics in resuscitation. The keyword assigns roles and responsibilities directly points to the critical importance of having clearly defined duties within a resuscitation team. When each team member understands their specific tasks, the process becomes organized, efficient, and less prone to errors, which is crucial in high-stress situations. For example, knowing who is doing compressions, who is managing the airway, and who is preparing medications streamlines the entire resuscitation effort. Question 4. You are managing a patient with symptomatic bradycardia. After atropine administration, the patient's heart rate remains 40 bpm, and blood pressure is 80/40 millimeter of mercury. What is the next most appropriate intervention? A. Administer adenosine 6 mg for push. B. Prepare for transcutaneous pacing. C. Administer an additional dose of atropine. D. Initiate immediate defibrillation. Answer B. Prepare for transcutaneous pacing. This question tests the management of symptomatic bradycardia, a key ACLS algorithm. The keywords symptomatic bradycardia, heart rate 40 bpm, BP 80/40 millimeter of mercury, and after atropine administration indicate that atropine has failed to improve the patient's condition. According to the ACLS bradycardia algorithm, if atropine is ineffective for symptomatic bradycardia, the next step is typically transcutaneous pacing, TCP, or dopamine/epinephrine infusion while awaiting pacing or a definitive solution. Adenosine is for narrow complex tachycardia, and defibrillation is for pulseless ventricular rhythms or unstable tachycardia, not bradycardia. Question 5. A 45-year-old patient is in cardiac arrest. After 2 minutes of CPR, the rhythm is determined to be ventricular fibrillation, VF. What is the appropriate immediate intervention? A. Administer epinephrine 1 mg 4/IO. B. Perform synchronized cardioversion. C. Deliver an immediate unsynchronized shock, defibrillation. D. Administer amiodarone 300 mg 4/IO. Answer C. Deliver an immediate unsynchronized shock, defibrillation. This question assesses knowledge of the pulseless arrest algorithm, specifically for shockable rhythms. The key phrase, ventricular fibrillation, VF, identifies a shockable rhythm in a patient in cardiac arrest. For VF, the primary and immediate intervention after 2 minutes of CPR is defibrillation, which is an unsynchronized shock, to attempt to terminate the chaotic electrical activity and restore a perfusing rhythm. Medications like epinephrine and amiodarone are given later in the algorithm if VF persists after initial shocks. Question 6. What is the recommended minimum depth for chest compressions in an adult? A. At least 1 inch 2.5 centimeters. B. At least 1.5 inches 3.8 centimeters. C. At least 2 inches 5 centimeters. D. At least 2.5 inches 6.4 centimeters. Answer C. At least 2 inches 5 centimeters. This question tests a fundamental component of high-quality CPR for adults. The critical concept is ensuring effective chest compressions. The guideline recommended minimum depth for adult chest compressions is at least 2 inches 5 centimeters but no more than 2.4 inches 6 centimeters, allowing for adequate blood flow to vital organs during cardiac arrest. Compress deeply enough to effectively circulate blood to the brain and heart, which is vital for patient survival. Question 7. A patient presents with a regular, narrow complex tachycardia at a rate of 160 bpm. The patient is alert, blood pressure is 110/70 mmHg, and they report mild palpitations. What is the most appropriate initial pharmacological intervention? A. Adenosine 6 mg rapid 4 push. B. Amiodarone 300 mg 4/10 minutes. C. Diltiazem 0.25 mg per kilogram 4. D. Synchronized cardioversion. Answer A. Adenosine 6 mg rapid 4 push. This question focuses on the management of stable narrow complex tachycardia. The key information is regular, narrow complex tachycardia at a rate of 160 bpm and the patient being alert with a stable blood pressure of 110/70 mmHg, indicating stability. For stable regular narrow complex tachycardia, the first-line pharmacological intervention is adenosine, which can temporarily block the AV node to diagnose and often terminate supraventricular tachycardias, SVTs. Synchronized cardioversion is for unstable tachycardias, and amiodarone or diltiazem might be considered for stable rhythms if adenosine fails or is contraindicated, but not as the initial drug for a regular narrow complex rhythm. Question 8. Which of the following is an absolute contraindication to the administration of nitroglycerin in a patient experiencing chest pain? A. History of chronic stable angina. B. Systolic blood pressure greater than 100 mm of mercury. C. Recent use, within 24 to 48 hours, of phosphodiesterase inhibitors, e.g., sildenafil, tadalafil. D. Absence of ST segment elevation on ECG. Answer: C. Recent use, within 24 to 48 hours, of phosphodiesterase inhibitors, e.g., sildenafil, tadalafil. This question tests critical pharmacology knowledge related to chest pain management. The keyword absolute contraindication for nitroglycerin requires specific awareness of scenarios where its use is extremely dangerous. The most critical contraindication for nitroglycerin is recent use of phosphodiesterase inhibitors, like sildenafil or tadalafil, as combining these drugs can cause severe, life-threatening hypotension due to profound vasodilation. While other options might be relative considerations, only recent phosphodiesterase inhibitor use is an absolute contraindication due to this severe drug interaction. Question 9. During advanced airway management in cardiac arrest, what is the recommended ventilation rate once a definitive airway, e.g., endotracheal tube, is in place? A. 1 breath every 3 to 5 seconds, 12 to 20 breaths/min. B. 1 breath every 5 to 6 seconds, 10 to 12 breaths/min. C. 1 breath every 6 to 8 seconds, 7 to 10 breaths/min. D. 1 breath every 2 to 3 seconds, 20 to 30 breaths/min. Answer: B. 1 breath every 5 to 6 seconds, 10 to 12 breaths/min. This question addresses ventilation rates after advanced airway placement during cardiac arrest. The concept is to provide adequate oxygenation without causing hyperventilation, which can be detrimental by increasing intrathoracic pressure and reducing venous return and cardiac output. Once an advanced airway is in place, compressions can be continuous, and ventilations should be delivered at a rate of 1 breath every 5 to 6 seconds, equaling about 10 to 12 breaths per minute, to avoid excessive ventilation. Question 10. A patient in cardiac arrest has persistent ventricular fibrillation despite 2 defibrillation attempts and an initial dose of epinephrine. What is the next most appropriate antiarrhythmic medication to administer? A. Lidocaine 1 to 1.5 mg/kg/4/IO. B. Adenosine 6 mg 4-push. C. Amiodarone 300 mg 4/IO. D. Magnesium sulfate 1 to 2 g 4/IO. Answer: C. Amiodarone 300 mg 4/IO. This question evaluates the pharmacological management of refractory shockable rhythms in cardiac arrest. The key information is persistent ventricular fibrillation after 2 defibrillation attempts and an initial dose of epinephrine. According to the pulseless arrest algorithm, if VF persists after initial shocks and epinephrine, the first-line antiarrhythmic is amiodarone at a dose of 300 mg 4/IO. Lidocaine is an alternative if amiodarone is unavailable or contraindicated, while adenosine is for tachycardia and magnesium is for torsades de pointes. Question 11. What does the D stand for in the ACLS Secondary Assessments ABCD Primary Survey? A. Drugs. B. Disability. C. Defibrillation. D. Diagnosis. Answer: B. Disability. This question tests knowledge of the ACLS secondary assessment's ABCD primary survey, specifically the D component. The primary survey in ACLS focuses on rapid identification and management of life-threatening conditions. D stands for disability, which involves quickly assessing the patient's neurological status using tools like AVPU, alert, voice, pain, unresponsive, or Glasgow Coma Scale, looking for signs of altered mental status, and checking pupillary response. This helps in understanding the brain's function and guiding further treatment. Question 12. A 70-year-old patient presents with a rapid, irregular wide complex tachycardia. They are hypotensive, BP 70/40 millimeter of mercury, and unresponsive. What is the immediate priority? A. Administer amiodarone 150 mg for over 10 minutes. B. Perform immediate synchronized cardioversion. C. Administer adenosine 6 mg rapid for push. D. Prepare for transcutaneous pacing. Answer: B. Perform immediate synchronized cardioversion. This question tests the management of unstable tachycardia. The critical clues are rapid, irregular wide complex tachycardia combined with signs of instability, hypotensive, BP 70/40 millimeter of mercury, and unresponsive. When a patient with tachycardia exhibits signs of instability, e.g., hypotension, altered mental status, signs of shock, acute heart failure, ischemic chest discomfort, immediate synchronized cardioversion is the priority, regardless of the specific rhythm, as delaying can lead to cardiac arrest. Question 13. What is the initial energy dose for unsynchronized defibrillation of ventricular fibrillation, VF, in an adult using a monophasic defibrillator? A. 120 joules. B. 200 joules. C. 360 joules. D. 100 joules. Answer: C. 360 joules. This question assesses specific knowledge regarding defibrillation energy settings. The key is initial energy dose, unsynchronized defibrillation, ventricular fibrillation, VF, and monophasic defibrillator. For a monophasic defibrillator, the recommended initial energy dose for VF is 360 joules, the maximum available energy. For biphasic defibrillators, the initial dose typically ranges from 120 to 200 joules, but the question specifies monophasic. Knowing the correct energy level is crucial for effective rhythm termination. Question 14. What is the primary purpose of capnography during cardiac arrest resuscitation? A. To confirm endotracheal tube placement. B. To monitor oxygen saturation levels. C. To indirectly monitor the effectiveness of chest compressions and guide prognosis. D. To assess the patient's respiratory rate. Answer: C. To indirectly monitor the effectiveness of chest compressions and guide prognosis. This question focuses on the utility of capnography during resuscitation. While capnography does confirm endotracheal tube placement, a vital function, its primary purpose during cardiac arrest is to monitor the effectiveness of chest compressions and indicate when return of spontaneous circulation, ROSC, has occurred. A sudden increase in end-tidal CO2, EtCO2, to greater than 35 to 40 millimeters of mercury often signals ROSC, and maintaining EtCO2 above 10 millimeters of mercury during CPR suggests adequate compression quality. This real-time feedback helps optimize resuscitation efforts. Question 15. A patient has received 0.5 milligrams of atropine for symptomatic bradycardia. What is the maximum total dose of atropine that can be administered for this indication? A. 1 milligram. B. 2 milligrams. C. 3 milligrams. D. for milligrams? Answer C. 3 milligrams. This question tests specific drug dosage knowledge for symptomatic bradycardia. The concept is understanding the total permissible dose for atropine. The maximum total dose of atropine for symptomatic bradycardia is 3 milligrams, given in 0.5 milligrams 4 boluses every 3 to 5 minutes. Exceeding this dose is generally not recommended as it does not provide additional benefit and can lead to paradoxical bradycardia or other adverse effects. Question 16. What is the recommended chest compression to ventilation ratio for a single rescuer performing CPR on an adult? A. 15:2. B. 30:2. C. 5:1. D. Continuous compressions with one breath every 6 seconds. Answer B. 30:2. This question targets foundational BLS knowledge essential for ACLS. The key concept is the correct ratio for chest compressions and ventilations for a single rescuer in adult CPR. For a lone rescuer on an adult, the ratio is 30 compressions followed by 2 ventilations, allowing for effective circulation and oxygenation. Continuous compressions with asynchronous ventilations are reserved for when an advanced airway is in place. Question 17. What is the maximum recommended time to interrupt chest compressions for a rhythm analysis and defibrillation? A. No more than 5 seconds. B. No more than 10 seconds. C. No more than 15 seconds. D. No more than 20 seconds. Answer B. No more than 10 seconds. This question emphasizes the importance of minimizing hands-off time during CPR. The core concept is high-quality CPR, and the critical phrase, maximum recommended time to interrupt, highlights the need for continuous compressions. Pauses in chest compressions should be minimized to no more than 10 seconds for rhythm analysis, defibrillation, or airway management, as longer interruptions significantly reduce coronary perfusion pressure and decrease survival rates. Every second of compression counts in maintaining blood flow to the brain and heart. Question 18. Which of the following is considered a non-shockable rhythm in the pulseless arrest algorithm? A. Ventricular fibrillation, VF. B. Pulseless ventricular tachycardia, private. C. Asystole. D. Monomorphic ventricular tachycardia with a pulse. Answer C. Asystole. This question assesses the ability to differentiate between shockable and non-shockable rhythms in cardiac arrest. The concept is central to the pulseless arrest algorithm. Asystole, which appears as a flat line on the ECG, signifies the absence of electrical activity and is a non-shockable rhythm. Ventricular fibrillation, VF, and pulseless ventricular tachycardia, private, are shockable rhythms, while monomorphic VT with a pulse is a perfusing rhythm not in cardiac arrest, managed by the tachycardia algorithm. Question 19. A patient in cardiac arrest has been successfully defibrillated from VF and now has ROSC. What is the immediate goal for post-cardiac arrest care related to oxygenation? A. Titrate oxygen to maintain SpO2 greater than 98%. B. Administer 100% oxygen regardless of SpO2. C. Titrate oxygen to maintain SpO2 between 92 to 98%. D. Discontinue oxygen as soon as SpO2 reaches 90%. Answer C. Titrate oxygen to maintain SpO2 between 92 to 98%. This question tests knowledge of post-cardiac arrest oxygenation strategies. The key concept is avoiding both hypoxia and hyperoxia too little or too much oxygen, both of which can worsen outcomes after cardiac arrest. The guideline recommends titrating oxygen to maintain an arterial oxygen saturation, SpO2, between 92 to 98% to optimize tissue oxygen delivery without causing hyperoxia, which can lead to vasoconstriction and increased oxidative stress. Question 20. You are responding to a patient with suspected stroke. What is the single most important piece of information to obtain from the patient or family? A. Detailed past medical history. B. Time of symptom onset, last known normal. C. Current medication list. D. Social history, including smoking and alcohol use. Answer: B. Time of symptom onset, last known normal. This question focuses on critical information gathering in stroke management. The keyword single most important piece of information highlights the priority. The time of symptom onset, or last known normal, is absolutely crucial for stroke patients because it determines eligibility for time-sensitive reperfusion therapies like intravenous thrombolytics, TPA, or mechanical thrombectomy. These therapies have strict time windows, so knowing when symptoms began dictates treatment pathways. Question 21. What is the recommended dose of epinephrine for cardiac arrest? A. 0.5 mg 4/IO every 3 to 5 minutes. B. 1 mg 4/IO every 3 to 5 minutes. C. 2 mg 4/IO every 5 to 10 minutes. D. 0.1 mg per kilogram 4/IO once. Answer: B. 1 mg 4/IO every 3 to 5 minutes. This question tests fundamental pharmacology in cardiac arrest management. The concept is the correct dose and frequency of epinephrine, a cornerstone medication in the ACLS algorithm. The recommended dose of epinephrine for cardiac arrest is 1 mg administered intravenously, or intraosseously, IO, every 3 to 5 minutes, regardless of the presenting rhythm, shockable or non-shockable. This consistent dosing helps maintain coronary and cerebral perfusion pressure during resuscitation. Question 22. Which of the following ECG findings is characteristic of atrial fibrillation? A. Regular RR intervals with P waves for every QRS. B. Irregularly irregular RR intervals with no discrete P waves. C. Sawtooth pattern of P waves with regular RR intervals. D. Wide QRS complexes with a rate greater than 100 BPM. Answer: B. Irregularly irregular RR intervals with no discrete P waves. This question tests ECG interpretation, specifically identifying atrial fibrillation, AF. The characteristic ECG features of atrial fibrillation are an irregularly irregular RR interval, meaning no discernible pattern to the irregularity, and the absence of discrete P waves, which are replaced by chaotic atrial activity. This contrasts with other rhythms like sinus rhythm, regular RR, P for every QRS, or atrial flutter, sawtooth P waves. Question 23. A 55-year-old male is unresponsive and apneic. You feel a carotid pulse. What is the immediate next step? A. Start chest compressions. B. Open the airway and provide rescue breaths. C. Attach the AED/defibrillator pads. D. Administer naloxone. Answer: B. Open the airway and provide rescue breaths. This question tests the initial assessment and management of a patient who is unresponsive and not breathing but has a pulse, aligning with BLS principles essential for ACLS. The critical finding is unresponsive and apneic with a carotid pulse. In this scenario, the patient is experiencing respiratory arrest, not cardiac arrest. Therefore, the immediate next step is to open the airway, e.g., head tilt, chin lift or jaw thrust, and provide rescue breaths to oxygenate the patient, rather than starting chest compressions, which are for pulseless patients, or applying a defibrillator. Question 24. What is the initial energy dose for synchronized cardioversion of unstable monomorphic ventricular tachycardia in an adult? A. 50 joules. B. 100 joules. C. 120 to 200 joules, biphasic, or 200 joules, monophasic. D. 360 joules. Answer, B. 100 joules. This question focuses on synchronized cardioversion energy levels for specific arrhythmias. The key is initial energy dose, synchronized cardioversion, and unstable monomorphic ventricular tachycardia. For unstable monomorphic VT, the recommended initial synchronized cardioversion energy is 100 joules using either a monophasic or biphasic device. This relatively lower initial dose is often effective for monomorphic VT, with subsequent shocks increased if the first is unsuccessful. Question 25. Which intervention is not recommended during the immediate post-cardiac arrest period for a patient with ROSC? A. Therapeutic hypothermia. B. Control of blood glucose levels. C. Avoidance of hyperoxia. D. Routine prophylactic antiarrhythmic drug administration. Answer, D. Routine prophylactic antiarrhythmic drug administration. This question probes knowledge of post-cardiac arrest care, specifically what to avoid. The concept is optimizing recovery and preventing harm. While various interventions are crucial after ROSC, like therapeutic temperature management, glucose control, and avoiding hyperoxia, routine prophylactic, preventative, antiarrhythmic drug administration is generally not recommended. Antiarrhythmics are used to treat specific arrhythmias that occur, but their routine use without a specific indication can cause more harm than good and is not supported by current guidelines. Question 26. In the context of the BLS survey, what does the C stand for? A. Consciousness. B. Chest compressions. C. Circulation. D. CPR. Answer, B. Chest compressions. This question tests basic life support, BLS, assessment sequence, which is foundational for ACLS. The C in the updated BLS sequence, CAB, stands for chest compressions. This change from the traditional ABC emphasizes starting compressions early to provide immediate blood flow to vital organs, as delay can significantly worsen outcomes in cardiac arrest. Remember, circulation, specifically effective chest compressions, is paramount. Question 27. A patient presents with acute pulmonary edema and severe respiratory distress. They are hypotensive. What is the most appropriate initial pharmacological intervention? A. Nitroglycerin. B. Furosemide. C. Morphine. D. Norepinephrine. Answer, D. Norepinephrine. This question assesses the management of acute pulmonary edema with associated hypotension, a critical aspect of ACLS. The key conditions are acute pulmonary edema, severe respiratory distress, and crucially, hypotensive. While nitroglycerin, furosemide, and morphine are commonly used for acute pulmonary edema with normal or elevated blood pressure, a hypotensive patient requires immediate support for blood pressure. Norepinephrine, a vasopressor, is indicated to increase blood pressure and improve perfusion in hypotensive shock, which takes priority over reducing preload or afterload with other agents in this specific hypotensive context. Question 28. What is the correct rate for chest compressions in an adult? A. 60 to 80 compressions per minute. B. 80 to 100 compressions per minute. C. 100 to 120 compressions per minute. D. 120 to 140 compressions per minute. Answer: C. 100 to 120 compressions per minute. This question tests another crucial component of high-quality CPR. The concept is maintaining an adequate compression rate for effective blood flow. The guideline recommended rate for chest compressions in an adult is 100 to 120 compressions per minute. This rate ensures that enough compressions are delivered to maintain circulation without causing rescuer fatigue too quickly or being too slow to be effective. Question 29. A patient presents with a regular, wide complex tachycardia at a rate of 180 bpm. They are alert and conscious with stable blood pressure, 120/80 mmHg. What is the initial recommended treatment? A. Immediate synchronized cardioversion. B. Administer adenosine 6 mg for push. C. Consider 4 antiarrhythmics like procainamide, amiodarone, or sotalol. D. Perform vagal maneuvers. Answer: C. Consider 4 antiarrhythmics like procainamide, amiodarone, or sotalol. This question tests the management of stable wide complex tachycardia. The key information is regular, wide complex tachycardia with the patient being alert and conscious with stable blood pressure. For stable wide complex tachycardias, the initial treatment often involves expert consultation and consideration of intravenous antiarrhythmic medications such as procainamide, amiodarone, or sotalol. Adenosine is typically reserved for narrow complex tachycardias, or to diagnose certain wide complex rhythms, and synchronized cardioversion is only indicated if the patient becomes unstable. Question 30. During a resuscitation attempt, the team becomes disorganized, with members repeating tasks and speaking over each other. Which element of effective team dynamics is lacking? A. Delegation of tasks. B. Mutual respect. C. Clear communication. D. Knowing your limitations. Answer: C. Clear communication. This question tests understanding of effective team dynamics in a high-stress medical environment. The scenario describes members repeating tasks and speaking over each other, which clearly indicates a breakdown in clear communication. Effective communication, including closed-loop communication and speaking clearly, is essential for coordination, preventing errors, and ensuring efficient execution of tasks during a resuscitation. Question 31. What is the most common reversible cause of pulseless electrical activity, PEA, that can be identified and treated in the field? A. Hypothermia. B. Tension pneumothorax. C. Cardiac tamponade. D. Thrombosis, pulmonary or coronary. Answer: B. Tension pneumothorax. This question addresses reversible causes of PA, pulseless electrical activity, often referred to as the HS and TS. The key is most common reversible cause in the field. While all options are HS and TS, a tension pneumothorax is often clinically identifiable, e.g., tracheal deviation, unilateral breath sounds, jugular venous distension, and treatable in the field with needle decompression, making it a crucial and potentially reversible cause to consider quickly. Question 32. A patient with ROSC post-cardiac arrest is unresponsive and remains comatose. Which intervention should be considered to improve neurological outcome? A. Induced hyperthermia to 38 degrees Celsius. B. Therapeutic temperature management, TTM, to target 32 to 36 degrees Celsius for at least 24 hours. C. Immediate cessation of all sedation. D. Aggressive intravenous fluid boluses to maintain high blood pressure. Answer: B. Therapeutic temperature management, TTM, to target 32 to 36 degrees Celsius for at least 24 hours. This question tests knowledge of post-cardiac arrest care, specifically interventions to improve neurological outcomes in comatose patients. The concept is therapeutic temperature management, TTM, formerly known as therapeutic hypothermia. For adult patients who remain comatose after ROSC from cardiac arrest, TTM, maintaining a target temperature between 32 degrees Celsius and 36 degrees Celsius for at least 24 hours, is recommended to protect the brain and improve neurological recovery. Question 33. What is the primary purpose of defibrillation? A. To restart the heart from asystole. B. To convert a perfusing rhythm to a non-perfusing one. C. To depolarize a critical mass of myocardial cells simultaneously to terminate a chaotic rhythm. D. To stimulate the heart to beat faster in bradycardia. Answer: C. To depolarize a critical mass of myocardial cells simultaneously to terminate a chaotic rhythm. This question tests the fundamental physiological principle of defibrillation. The core concept is how defibrillation works to stop life-threatening arrhythmias. Defibrillation delivers a high-energy electrical shock designed to simultaneously depolarize a critical mass of myocardial cells, essentially resetting the heart's electrical activity. This momentary cessation of all electrical activity allows the heart's natural pacemaker, SA node, to hopefully resume a normal, perfusing rhythm, thus terminating chaotic rhythms like VF or pulseless VT. Question 34. What medication is primarily used to treat torsades de pointes? A. Atropine. B. Lidocaine. C. Magnesium sulfate. D. Amiodarone. Answer: C. Magnesium sulfate. This question tests specific pharmacological treatment for a unique polymorphic ventricular tachycardia. The key rhythm is torsades de pointes, which is a distinct form of polymorphic ventricular tachycardia often associated with a prolonged QT interval. The primary medication for treating torsades de pointes is magnesium sulfate, regardless of whether magnesium deficiency is confirmed, as it stabilizes cardiac cell membranes and helps correct the underlying electrical instability. Question 35. When managing a patient with acute coronary syndrome, ACS, what is the maximum number of nitroglycerin doses that can be administered sublingually or as spray, if the patient has persistent chest pain and no contraindications? A. 1 dose. B. 2 doses. C. 3 doses. D. 4 doses. Answer: C. 3 doses. This question tests the safe administration of nitroglycerin in the context of acute coronary syndrome. The concept is the typical protocol for nitroglycerin administration for chest pain. If a patient with suspected ACS has persistent chest pain after the initial dose of nitroglycerin, up to 2 additional doses, for a total of 3 doses, can be administered every 3 to 5 minutes, provided the patient remains hemodynamically stable, e.g., systolic BP greater than 90 to 100 mm of mercury, and has no contraindications. Question 36. What is the recommended next step after administering epinephrine for a patient in asystole during cardiac arrest? A. Deliver an immediate unsynchronized shock. B. Resume chest compressions for 2 minutes. C. Administer amiodarone. D. Prepare for transcutaneous pacing. Answer: B. Resume chest compressions for 2 minutes. This question addresses the sequence of interventions in the pulseless arrest algorithm for non-shockable rhythms. After administering epinephrine for asystole, the critical next step is to immediately resume chest compressions for 2 minutes, 1 CPR cycle, before reassessing the rhythm. This ensures continuous blood flow and allows time for the medication to circulate and take effect. Defibrillation is not indicated for asystole, and amiodarone is for shockable rhythms. Question 37. You are assessing an adult patient who is unresponsive, not breathing, and has no pulse. What is the correct sequence of actions? A. Airway, breathing, circulation, ABC. B. Circulation, airway, breathing, CAB. C. Breathing, circulation, airway, BCA. D. Defibrillation, airway, breathing, circulation, DABC. Answer: B. Circulation, airway, breathing, CAB. This question tests the fundamental sequence of BLS and ACLS. The concept is the prioritized order of interventions for a patient in cardiac arrest. For an unresponsive, apneic, and pulseless adult, the current guideline emphasizes circulation, airway, breathing, CAB, meaning initiate chest compressions first, then open the airway and provide breaths. This change prioritizes immediate blood flow to the vital organs over ventilation. Question 38. A patient has been successfully resuscitated from cardiac arrest, and the physician is now considering management of potential brain injury. What is a key initial concern regarding ventilation targets in this post-cardiac arrest patient? A. Target a PaCO2 of 20 to 25 mm of mercury to induce hypocapnia. B. Avoid hyperventilation to prevent cerebral vasoconstriction. C. Provide deep breaths at a rate of 20 breaths/min. D. Maintain full ventilatory support indefinitely. Answer: B. Avoid hyperventilation to prevent cerebral vasoconstriction. This question tests critical aspects of post-cardiac arrest respiratory management, particularly as it relates to brain injury. The concept is avoiding hyperventilation in the post-ROSC period. Overly aggressive ventilation, hyperventilation, can lead to hypocapnia, low CO2, which causes cerebral vasoconstriction, reducing blood flow to the brain and potentially worsening neurological injury. Therefore, avoiding hyperventilation by titrating ventilation to maintain a normal PaCO2, typically 35 to 45 mm of mercury, is crucial. Question 39. What is the primary method for confirming proper endotracheal tube (ETT) placement in an adult during cardiac arrest? A. Auscultation of bilateral breath sounds. B. Absence of sounds over the epigastrium. C. Continuous quantitative waveform capnography. D. Visualization of the tube passing through the vocal cords. Answer: C. Continuous quantitative waveform capnography. This question emphasizes the most reliable method for confirming advanced airway placement. The concept is airway management during resuscitation. While auscultation, absence of epigastric sounds, and visualization are important initial steps, continuous quantitative waveform capnography is the most reliable method for confirming and continuously monitoring proper endotracheal tube placement during cardiac arrest, as it provides real-time confirmation of CO2 exhalation from the lungs. Question 40. A patient in cardiac arrest has a rhythm of pulseless electrical activity, PEA. What is the most appropriate initial pharmacological intervention? A. Amiodarone 300 mg 4/IO. B. Atropine 1 mg 4/IO. C. Epinephrine 1 mg 4/IO. D. Sodium bicarbonate 1 milliequivalent/kg4. Answer: C. Epinephrine 1 mg 4/IO. This question assesses the initial pharmacological treatment for PEA in cardiac arrest. The concept is the general approach to non-shockable rhythms. For pulseless electrical activity, PEA, as with asystole, the primary pharmacological intervention is epinephrine 1 mg 4/IO, administered every 3 to 5 minutes, along with high-quality CPR and the search for and treatment of reversible causes, HS and TS. Amiodarone is for shockable rhythms, atropine for symptomatic bradycardia, and sodium bicarbonate is not routinely used in cardiac arrest unless specific indications exist. Question 41. A patient with ROSC begins to develop recurrent ventricular fibrillation. The team plans to administer an antiarrhythmic. What dose of lidocaine would be appropriate as a first-line alternative to amiodarone in this situation? A. 0.5 to 0.75 mg/kg4/IO. B. 1 to 1.5 mg/kg4/IO. C. 2 to 3 mg/kg4/IO. D. 100 mg 4/IO stat. Answer: B. 1 to 1.5 mg/kg4/IO. This question tests specific pharmacology for recurrent VF after ROSC. The concept is the appropriate dosing of lidocaine as an antiarrhythmic. For recurrent ventricular fibrillation/pulseless VT, or as an alternative to amiodarone, the initial bolus dose of lidocaine is 1 to 1.5 mg/kg4/IO. This dose aims to stabilize the cardiac rhythm and prevent further recurrence of life-threatening ventricular arrhythmias. Question 42. What is the purpose of the initial rapid assessment, BLS survey, in ACLS? A. To identify and treat the underlying cause of the patient's condition. B. To identify and correct immediate life threats. C. To collect a detailed patient history and perform a comprehensive physical exam. D. To determine the patient's prognosis. Answer: B. To identify and correct immediate life threats. This question addresses the fundamental purpose of the BLS survey as the first step in ACLS. The core concept is rapid assessment in emergencies. The BLS survey, CAB, then defibrillation, is designed to quickly identify and correct immediate life threats such as cardiac arrest, by initiating CPR and defibrillation if needed, or respiratory arrest, by providing ventilations. It is a rapid, hands-on assessment focused on critical interventions, not a detailed diagnostic workup or history-taking. Question 43. When should a healthcare provider activate the emergency response system for an unresponsive adult who is not breathing normally and has no pulse? A. After delivering 5 cycles of CPR. B. Immediately after recognizing cardiac arrest. C. After checking for a pulse for 30 seconds. D. While performing the secondary assessment. Answer: B. Immediately after recognizing cardiac arrest. This question emphasizes the immediate need for emergency activation in cardiac arrest. The concept is efficient emergency response. For an unresponsive adult who is not breathing normally and has no pulse, the emergency response system should be activated immediately upon recognition of cardiac arrest. This ensures that advanced life support personnel and equipment can arrive as quickly as possible, minimizing delays to definitive treatment. Question 44. patient in cardiac arrest has a P wave preceding each QRS complex, but the QRS complexes are wide and irregular, and the rate is 40 bpm. There is no pulse. What rhythm is this consistent with? A. Ventricular fibrillation, VF. B. Asystole. C. Pulseless electrical activity, PEA. D. Symptomatic bradycardia. Answer, C. Pulseless electrical activity, PEA. This question challenges ECG interpretation in the context of cardiac arrest. The keywords P wave preceding each QRS complex, wide and irregular QRS complexes, rate is 40 bpm, and crucially no pulse point to pulseless electrical activity, PEA. PEA is characterized by organized electrical activity on the ECG, which can be any rhythm with electrical activity, not just normal sinus, but without a palpable pulse. This differentiates it from VF, asystole, or symptomatic bradycardia, which has a pulse. Question 45. What is the target end-tidal CO2, EtCO2, value that suggests adequate chest compression quality during CPR? A. Less than 5 mm of mercury. B. 5 to 9 mm of mercury. C. Greater than 10 mm of mercury. D. Greater than 45 mm of mercury. Answer, C. Greater than 10 mm of mercury. This question tests the interpretation of capnography during resuscitation. The concept is using EtCO2 as a real-time monitor for CPR effectiveness. During CPR, an end-tidal CO2, EtCO2, value consistently greater than 10 mm of mercury suggests that chest compressions are of adequate quality, providing sufficient blood flow to the lungs for gas exchange. If EtCO2 is consistently below 10 mm of mercury, it indicates very poor quality CPR or profound circulatory compromise. Question 46. A 48-year-old patient presents with shortness of breath, chest discomfort, and new-onset atrial fibrillation with a rapid ventricular response, rate 150 bpm. Her blood pressure is 88/50 mmHg. What is the most appropriate initial intervention? A. Administer diltiazem 4. B. Perform synchronized cardioversion. C. Administer amiodarone 4. D. Start a beta blocker 4. Answer, B. Perform synchronized cardioversion. This question tests the management of unstable tachycardia. The critical information is new-onset atrial fibrillation with a rapid ventricular response, rate 150 bpm, combined with signs of instability, blood pressure is 88/50 mmHg, hypotension, and shortness of breath, chest discomfort. Regardless of the specific tachycardia rhythm, if the patient is unstable, e.g., hypotensive, acutely altered mental status, signs of shock, ischemic chest discomfort, acute heart failure, immediate synchronized cardioversion is the most appropriate and life-saving intervention. Question 47. You are part of a resuscitation team. The team leader asks you to prepare epinephrine 1 mg 4. You confirm you heard the order and that you are preparing the medication. This is an example of what communication technique? A. Debriefing. B. Role clarity. C. Closed-loop communication. D. Constructive intervention. Answer, C. Closed-loop communication. This question focuses on essential communication skills in team dynamics. The scenario describes confirm, ing, you heard the order and that you are preparing the medication after receiving a command. This is a classic example of closed-loop communication, where the receiver repeats the message back to the sender, ensuring the message was received and understood correctly, and then confirms completion of the task. This technique minimizes miscommunication and errors in high-stakes environments. Question 48. In the post-cardiac arrest setting, what is the significance of maintaining adequate glucose control? A. To prevent hyperglycemia, which can worsen neurological outcomes. B. To induce hypoglycemia to improve brain metabolism. C. To increase circulating glucose for energy. D. Glucose control is not a significant concern after ROSC. Answer: A. To prevent hyperglycemia, which can worsen neurological outcomes. This question addresses a critical aspect of post-cardiac arrest care. The concept is the importance of blood glucose management. Maintaining adequate glucose control by preventing hyperglycemia, high blood sugar, is important after ROSC because hyperglycemia has been associated with worsened neurological outcomes in patients post-cardiac arrest, potentially exacerbating brain injury. Therefore, blood glucose levels should be monitored and controlled to avoid excessively high levels. Question 49. Which of the following conditions is an indication for transcutaneous pacing? A. Pulseless ventricular tachycardia, private. B. Symptomatic bradycardia unresponsive to atropine. C. Asystole. D. Atrial fibrillation with rapid ventricular response. Answer: B. Symptomatic bradycardia unresponsive to atropine. This question tests the indications for transcutaneous pacing, TCP. The concept is applying the bradycardia algorithm. Transcutaneous pacing is indicated for symptomatic bradycardia when atropine has been administered and is ineffective, or when the bradycardia is severe and symptomatic, warranting immediate electrical support. It is not used for pulseless rhythms like private or asystole, for which defibrillation or CPR/epinephrine are used, respectively, nor for fast rhythms like atrial fibrillation. Question 50. During the management of an unresponsive patient, what is the initial step after ensuring scene safety? A. Check for a pulse. B. Open the airway. C. Assess for responsiveness. D. Call for help/activate the emergency response system. Answer: C. Assess for responsiveness. This question evaluates the very first step in the BLS assessment. The concept is the initial approach to an unresponsive patient. After ensuring scene safety, the very first action is to assess for responsiveness by tapping and shouting at the patient. If the patient is unresponsive, then the next steps, like activating the emergency response system and checking for pulse/breathing, follow. This initial assessment guides the subsequent crucial actions.